Morning everyone. On behalf of ISECCon 2021, allow me to extend a warm welcome to you. I would like to take this opportunity to talk to you about our experience on rupture of ascending aortic pseudoaneurysm and its management. A stitch in time saves 9 expresses it's better to spend a little time and effort to deal with right now than to wait until later, where it may get worse and take longer time to deal with it. Let me start with some general information on ascending aortic pseudoaneurysm. Ascending aortic pseudoaneurysm results from transmural disruption of the aortic wall with a leak contained by surrounding mediastinal structures. It is a rare life-threatening complication after cardiac surgery and aortic surgery, and it can occur consequent to infection, genetic disorders, or trauma, and it can be from previous surgery requiring cannulation sites, venting sites, proximal vein graft anastomotic sites, and aortotomy sites. Pseudoaneurysm eroding the sternum will be a challenge for the surgeon and the perfusionist. The complications associated with intervening such pseudoaneurysm have a high morbidity and mortality rates. Here we discuss about our case report. A 69-year-old male presented with recurrent inflammation along the midline in the upper part of the chest with palpitation. He had a previous history of ASD closure in 1982 and PTCA to a lady artery in 2016. His computed tomography of chest which showed an expansile sternal mass and patient was transferred to our hospital. CT aortogram was performed which showed an saccular distal ascending aortic pseudoaneurysm with eccentric thrombus eroding into the manubrium. An appropriate approach was planned to overcome the risk and complication associated with the surgery. When you come to perfusion strategy, the right femoral artery and left common carotid artery were assessed for arterial inflow with 7 mm graft and right femoral vein for venous drainage with 24-29 venous cannula. Before sternotomy, cardiopulmonary bypass was instituted. The patient was cooled to 18 degrees Celsius. After reaching the temperature of 18 degrees Celsius, redo sternotomy was performed. During the time of redo sternotomy, ascending aortic pseudoaneurysm was inadvertently entered and got ruptured. The patient was made to Trendelenburg position. The femoral perfusion was stopped. The left common carotid artery was clamped below the anastomosis of the graft in the neck and unilateral brain perfusion was continued. The flow rate of 8 to 12 ml per kg was maintained to secure cerebral perfusion, and meantime the visceral organs are protected with hypothermia. The perfusion pressure of 60 to 80 millimeter mercury was maintained. The methylprednisolone was administered. This is a picture to show the antegrade cerebral perfusion continued to left common carotid artery. Through the defect in the proximal ascending aorta, active bleeding was present. To avoid exsanguinization and to enable a better surgical view, it was temporarily occluded with Fogarty catheter. Additions around the heart released. The heart was vented through the rent in the aorta. When the aorta was isolated, a side biting clamp was applied on the aortic rent and femoral perfusion was re-established. Aorta was delaminated and then aortic cross clamp was applied and leninocardioplegia was administered into the aortic root. Ascending aorta was excised and replaced with a 28 mm parasitic graft with Teflon filled outside the aorta. Patient rewarmed and weaned from CPB with satisfactory hemodynamic result and was transferred to the cardiac care unit in stable condition. Patient intra-op ABG value shows an elevation in lactate level at 18 degrees Celsius. His lactate level was 3.5 at 18 degree and during rewarming at 36 degrees Celsius, his lactate level was 5.4. Patient total pump time was 180 minutes and aortic cross clamp time was 43 minutes. TCA with unilateral perfusion time was 42 minutes. Postoperatively, patient was awake and recovered without any neurological sequelae and was extubated on day 1. Patient renal parameters during preoperative and postoperative and at the time of discharge it was normal. Patient had lactic acidosis in POD0 which settled on day 1. For managing such ascending aortic pseudoaneurysm, strategies needed to be formulated like cannulation strategies, degree of hypothermia, pharmacological adjuvants, topical external cooling of the head, the degree of hemodilution, strategies of cooling and rewarming, acid base management are needed to be formulated. When we come to cannulation strategies, peripheral cannulation sites must be chosen. Our choice was combination of femoral artery and left common carotid artery for establishment of CPB and cerebral blood flow during circulatory arrest. The surgeon's decision to institute axillary, femoral or carotid CPB will depend on the nature of each case. Disadvantages of cannulating other than carotid artery is if we cannulate only axillary artery or with right femoral artery. In case of rupture, there will be a lack of space for clamping and continuing cerebral perfusion. If the cannulation is only on femoral artery, in case of rupture, we cannot able to establish brain perfusion during the TCA. During cerebral perfusion, the patient is put on Trendelenburg position and strategy of continued cerebral perfusion during arrest exists. Usually it will be an antegrade cerebral perfusion via the carotid arteries and the flow rate of 8 to 12 ml per kg was maintained with the pressure of 60 to 80 millimeter of mercury. This perfusion strategy were developed to prolong circulatory arrest times. Metabolic oxygen demand are generally cut in half with each reduction of 10 degrees Celsius in body temperature. Deep hypothermia to 18 degrees Celsius allow total circulatory arrest for complex repairs for 45 to 60 minutes. Neuroprotective drugs like barbiturates, corticosteroids, inhaled anesthetics, lidocaine, magnesium mannitol reduces excitotoxicity, reduces calcium influx, and it acts as an anti-inflammatory properties to improve cerebral blood flow. In neuromonitoring, the nasopharyngeal temperature exhibit the best correlation with the cerebral temperature. NIRS is a technology that monitors regional cerebral O2 saturation by using transcranial near infrared light to measure the ratio of oxygen to deoxygenated hemoglobin. It is used for detection of changes in oxygen saturation also. In acid base management, usually in adults, it is alpha stat management. This is a case report with a similar strategy was reported from the University of Miami Hospital. I hereby conclude that in patients with ascending aortic pseudoaneurysm, eroding the sternum is a formidable challenge. A careful preoperative planning can enable safe entry. A combination of techniques can mitigate and minimize blood loss. The method for preservation of cerebral perfusion and visceral protection should be considered. The surgeon's decision to institute axillary, femoral or carotid CPB will depend on the nature of each case. The appropriate use of hypothermic circulatory arrest enables mediastinal dissection and aortic control. Every case of ascending aortic pseudoaneurysm is individual and should be managed accordingly.